All right, I've got noon. So welcome all. We have participants from all 5 continents here. This is the joint AAST PTS International Case Conference where we present 1 hour's worth of cases from around the world in trauma centers and non-trauma centers that are then looked at by a panelist of expert trauma surgeons from also around the world. And there's discussion, interaction, and collegial communication on how we can do things better or how things can be done alternatively in an austere environment or in an area where the resources may not be as ample. Dr. Martos from the PTS, Pan American Trauma Society, has initiated the PTS version of this presentation, International Case Conference, for years. Many of the viewers joined from that group of participants, but the AAST has joined this effort for about a year now per an MOU of Dr. Bulger in her presidency. So I'm going to not delay things. I'm going to introduce on behalf of Dr. Buhavac, Milos Buhavac, who was supposed to moderate for the AAST, has been delayed and is in flight. The presenters, so the presenters from the AAST is Dr. Krause and Dr. Hewgley from the University of Alabama in Birmingham. The distinguished panelists are Dr. Holcomb, Dr. Chestovich, and Dr. Brooks. And so I'll let Dr. Menagoza introduce the PTS slate.
Great, thank you, Dr. Pasquale. So on the PTS side, we're going to have Dr. Daniel Pust to present the case. Dr. Daniel Pust is from the University of Miami Miller School of Medicine, and we'll also have the pleasure to have Dr. Abutanos as one of the panelists. Dr. Abutanos is a distinguished professor in surgery, chief of the Division of Acute Care Surgical Services, Department of Surgery, and medical director of the VCU Trauma Center. So I think we're going to have a really interesting discussion today.
Excellent. Unless there's any other comments, Dr. Krause, please go ahead and share your presentation. We'll let you know if we need to pause. Thank you.
Okay, I'll do. All right. Good morning, everyone. Thank you for the invitation to present. Specifically, I want to thank Dr. Cox, who is one of the attendings in this case, and also Dr. Holcomb for this opportunity. My name is Cassandra Krause. I just completed Trauma and Surgical Critical Care Fellowship at UAB and will be an attending at Loma Linda University in Southern California. And then my co-presenter, who unfortunately probably will not be able to make it due to a flight delay, is Dr. Preston Hewgley. He also finished at fellowship with me at University of Alabama and is staying there as an attending. Okay. Let's see. This was working. Is my slide not moving for you guys?
It's not moving.
Okay. There we go.
There we go.
All right. So some background to this case. This was an alert one. Transfer from an outside hospital. He's a 17-year-old male with a gunshot wound to the abdomen and back, as reported. His vitals paged out were relatively stable. Time of injury was 1600, and his ETA was 2 hours later at 1800. On arrival, he had stable vitals. His primary survey was relatively unremarkable, except that he was anxious and combative, suggesting a higher grade of shock than his vitals would tell us. On secondary, he had 2 missile wounds. One was in the central abdomen, you can see here from the drawing, and then the second was in the left back. The FAST exam was deferred as this was a penetrating wound. His chest x-rays are shown below. This was his chest x-ray. He had a left hemothorax. However, a chest tube was deferred in the bay due to hemodynamic stability in the absence of hypoxemia and no respiratory distress. His abdominal x-ray is shown here. He did not have any retained missiles. The presumed trajectory was between the 2 missile wounds. His pelvic exam was unremarkable. In summary of the trauma hall events, his arrival time was at 1807. He had antibiotics and TXA that were given within 7 minutes of his arrival, and then he was taken to the OR within 20 minutes of his arrival. CT scan.
Okay, go ahead. There was a CT scan that was done prior to the OR?
No, so CT scan was deferred. He was stable institutionally at UAB. The priority is to take to the OR for definitive hemorrhage control, even in patients that have a stable penetrating abdominal trauma. So that's why we deferred it.
Got it. So, Dr. Abutanos, would you have put a chest tube in here before heading to the operating room?
Debatable. Yeah, if he's hemodynamically stable, like we said, for us, we've noted that the sooner we get our patient to the OR that we're going to operate on, they're fine. I didn't see any. I just saw a little bit of a hemothorax. I would have deferred it to the OR. That's fine. My main question is why TXA, and is that routine at the University of Alabama to give TXA for everybody, even if they're stable and no evidence currently of bleeding?
Yeah, most patients with penetrating wounds, it's kind of just part of the protocol. They get it. He was within the window, so we got it. Arguably, he is stable, so yeah, I think it would be appropriate not to give it as well.
So we at UAB follow the DoD guideline based on a secondary analysis of the Ryle Schreiber study, and so he got 2 grams of TXA, which is our standard. If the patient is within the 3-hour window.
Dr. Brooks.
Many of these patients will have TXA pre-hospital as well. He did not.
Dr. Brooks, I haven't seen on the X-rays. If you could come back to the chest and abdomen, I didn't see a paperclip. You said it was mid-abdomen. Was it above the clavicle? Sorry, above the costal margin, below that the entry or both holes are?
It was pretty much right in the center of the abdomen. I agree, there is no paperclip. Typically, we do place them. I think that was probably missed.
So my question to Dr. Brooks is, should completely stable patient, lots of time, should we go to CAT scan first? Would that help?
Yeah, I think I certainly would have put paper clips on to give me some idea of trajectory if there's no other retained rounds there. And our institution, he'd have had pre-hospital TXA at the 2 grams mark. I think the temptation would have been to take him to the CAT scan and get a CT scan. His numbers look pretty stable. He's been 2 hours out, and he's got good vitals. So I think my temptation would have been to CT him.
Could it have changed anything? You're still heading to the operating room regardless?
Unlikely. You've got 2 wounds, so it's unlikely much, but it may have helped plan logistically as to what we are going to do. But I know it's quite tricky in my institution to avoid a CT scanner. It's kind of en route, and they kind of always want to stop if there's enough blood pressure to push the drugs around.
Dr. Jestovich, other thoughts? Or are we heading straight to the OR?
In my hands, I would take him straight to the OR. In this situation, I do not think I'd get a CT scan. It sounds like this gunshot went through pretty much center mass, and I think there's a high likelihood you're going to find something. Scenarios where I might consider a CT scan is if I thought the wound was tangential, or maybe it was in the pelvis. In that situation, maybe I want to see if there's a rectal injury, things like that. But I think based upon where this injury is, I think I'd go straight to the OR. One question I did have is, I know you mentioned he was combative. I'd be curious, 2 things. Did you get any kind of a gross neuro exam? Was he moving his lower extremities? Because based upon where this is, you have to think about a spinal injury. Based on the x-rays, doesn't look like he has one, but I'd still want to know. Second question is, how is he tender in his abdomen? Evidence of peritonitis. It probably wouldn't change what I do, but something I'd like to know ahead of time.
Yeah, he was tender in his abdomen. He was moving his lower extremities. He was able to follow commands, just definitely more anxious.
My issue is that the age. He's only 17 years old. That does influence. The young guy, they're fine until they're not. And that's my big issue with the scan. You may be faked into, hey, he's fine now, because quickly put on the scanner, then they crash on you in the scanner, and now you're behind. And that's part of the main reason. I agree. I would not, it's not going to change what I would do. I don't think it's going to give me anything additive. It's just going to delay my time.
another point I would make along with that is that you mentioned he was kind of combative, and so I'd be curious as to whether is he going to lie still for a CT scan? You know, is this a scenario where you take him to the scanner, he's rolling everywhere, then the nurses is asking for, can we give him some Versed to calm him down? You know, next thing you know, you got a hypotensive bleeding patient on the CT scanner, and so I think I would go straight to the OR.
You
All
know,
right, Dr.
sorry, Jose, I just want to just say, since this is a Pan-American, also site WASD, and as you know, the studies came from Dr. Ordonez, who has challenged all of us with the use of the CT scan in stable patients. But even with that, I still would have just went to the OR with this patient.
Thank you. Dr. Krause, keep us going.
Okay.
Jose, can I just jump in here real quick? Is that okay?
Yeah.
I completely agree with deferring the FAST exam and the CAT scan and going directly to the operating room in this patient. Couldn't say it stronger for all the reasons that have been articulated. And it's something we talk about every morning at UAB, at morning report.
Same at BCU.
Yeah.
I think there's a heavy American influence. I think I practice the same way, but when I started interacting with trauma surgeons in France and in Spain and now in England as well, there's a slight different approach to that. And the idea of having a patient die in CAT scan because they're already obviously injured in a very life-threatening way was challenged at many levels. So I'd love to hear dissenting opinions. All right, let's keep going because we don't want to delay things.
All right. In the OR, the injuries are all listed out below. The retroperitoneum was opened, and exploration of the pancreatic injury, I highlighted the two main areas that we're focusing on, was done. It appeared to be a parenchymal injury at the periphery in the inferior portion of the tail of the pancreas. There was some surrounding contusion, but there was no obvious fluid from the injury. There was no saponification. There was a very proximal small bowel injury right at the ligament of Treitz. The resection and anastomosis required division of the ligament of Treitz and mobilization of the fourth portion of the duodenum.
All right. How do we proceed? Oh, don't give us the answers. So how do we proceed from here? Let's start with Dr. Chestovich.
I think simply stop the bleeding first, stop the contamination second, in that order. So I think if this splenic injury is bleeding, I'm taking the spleen out. This left kidney laceration, I'm assuming you found that later because you would have had to do a retroperitoneal exposure over there to see that. So I'd take care of those first, suture off the bleeding. I think I'm doing damage control here. I'm gonna, I'm gonna debride these gastric injuries so I'm closed. Proximal jejunum, I'm gonna mobilize that, staple it off. This laceration of the inferior portion of the pancreas is pretty concerning. Have to find out a little bit more about it. Does it involve the duct or anything? But I'm probably just going to put drains in and then I'm going to apthere it and go to the ICU.
Dr. Abutanos, would you do something different? And how would you assess pancreatic duct injury involvement here?
I mean, I agree with stop bleeding first, contamination second. I actually would have done both the splenectomy and distal pancreatectomy at the same time. And a lot easier to do, and as part of the mobilization and the control. And I agree is that we'll have to see what the left kidney laceration is. So, but those would have been my my way of proceeding forward is what we discussed before. The only thing we did not mention is that the left hemothorax, usually we'll have somebody else quickly put that chest tube in just to make sure. And then when you're and then when we're inside, obviously, like I said, mentioned the distal pancreatectomy and splenectomy at the same time. Quickly control the gastric injuries. I definitely will do the same in terms of stapling the jejunal injuries, and then at that time I'll find out how is the patient doing. That's going to dictate what I would do, whether it would be proceeding with the damage control and stopping at this time, or doing any kind of repair to the jejunum at this time.
Dr. Abutanos is not committed to damage control. Dr. Chestovich is. Dr. Brooks, anything different?
Yeah, well, I already knew about the kidney laceration from the CT scan. So we went for that, and we could see, whether it was going to be a peripheral or involve the collecting system. So yeah, it's the same control. It's straightforward control of hemorrhage and then contamination. And I, like colleagues, would be tempted if I thought there was a distal. It depends where in the pancreas it is. It doesn't say. If it's inferior portion of the pancreas, clearly the management's different. If that's left, and you can do a distal pancreatectomy, but if it's not, and there's no reason to believe that it's anything other than left, then we're not going to do a 90% resection of the pancreas for a potentially non-duct injury. But yeah, we would do the same, control contamination. But I'm the same. I'm not definitely damage controlling at the moment. We kind of see where we are with viscoelastic assay, with TEG, where we are with numbers, where we are with gases, see how good the anesthesia team are today. And then we'll make a nuanced decision as time goes on.
Final comments, Dr. Holcomb?
No, I think the comments are very good. This guy was Dr. Cox, who's taking care of a patient with 4 gunshot wounds right now in the operating room, was the attending on the case. He was very stable, Adam. His TEG was normal. His base deficit was okay. He got a couple of units of whole blood and minimal crystalloid. And so we have, as we shifted, as most people have, from less crystalloid to more blood products, balanced blood products, whole blood, we're able to stay in the operating and fix injuries and close the fascia. As we've decreased our damage control rate from, it used to be 30 or 40% down to 15%. We talk about that quite a bit, and this guy fit that category very nicely.
I think a little bit like I'm trying to stop everyone CTing everyone with penetrating trauma. Trying to stop everybody damage control is equally a bit of a challenge.
Yeah,
we're finding out place damage control is like a spectrum almost of what you find different opinion exactly what is distal pancreatectomy and splenectomy not damage control since you stop. It's like this, we find these gradients in terms of when do you stop and when don't you. That's why I was asking about the physiological response of the patients, because that's really what dictates you, not the anatomical presence. That's where damage control should happen. Couldn't
agree more, Michael. Great comment.
Dr.
It's the
Krause.
physiology, not the anatomy.
Dr. Krause.
Yes. All right. I'll continue on. So just to clarify, it was inferior portion of the pancreas and to the left, as y'all assumed. We should have had that in there. All right. So multiple procedures is all in the first case, as you can see. Highlighted the specific ones we're kind of focusing on. As Dr. Holcomb alluded to, the patient was hemodynamically normal. He did not have any acidosis. His TEG was normal, and this was after hemorrhage control and control of contamination. So the decision was made to proceed with GI reconstruction with the hand-sewn duodenojejunectomy. So it's oriented in anti-peristaltic side-to-side fashion. The pancreas was felt to be a low-grade injury. They did not appear to be a duct injury from the initial exploration, and the perceived chance thought of developing a leak if leaving it alone with drains versus doing a distal pancreatectomy. We thought that the distal pancreatectomy leak might be a higher chance as opposed to controlling the pancreatic contusion with drains. But there was still a high concern for the pancreatic injury because it was very adjacent to the anastomosis. And so the decision was made to get postoperative CT scans more to serve as a baseline and to evaluate for evolution of the injury, and then obtain drain amylases and follow the drain content and character closely. Because the patient was stable and TEG, everything else was normal, we did proceed with fascial closure. And this was to avoid a planned second look. Felt that the combination of imaging and drain amylase, we could confidently diagnose a pancreatic leak and avoid a damage control operotomy. In the event of a pancreatic leak, we could always come back and reopen the fascia if needed.
Comments, anyone?
Yeah, I think that's the only thing I would have done different would have been I'd have done a distal pancreatectomy rather than take the risk of that pancreatic injury progressing, and you can't see where the actual how well the injury is, especially in its location. You've got a gastro repair there, you've got your hand-sewn anastomosis there. I kind of don't really want to leak, so that's the only different thing. But I would have been aiming for fascial closure just like you guys.
Dr. Avutanos and Chestovich, thoughts on not leaving the abdomen open and not doing a distal pancreatectomy?
But I think, so like I already mentioned, in my hand, I would have done it on the first case. The issue been for me is that you have a pancreatic leak next to your anastomosis. You already set yourself up for the leak, especially very high in the duodenum. So I would have on the second operation, yes, for sure, I would have closed and I would have already had my distal pectectomy. I would have put in the drain. I would have also given this guy a feeding jejunostomy distal anastomosis, especially if I've done the distal pancreatectomy. Just as a precaution, what we've seen before, and if we're going to close.
As far as leaving the abdomen open, I mean, I totally agree with the other panelists. I think if he was stable, you know, TEG is normal, not hypotensive, bleeding's controlled, in that situation, I could be convinced to go ahead and do it in one operation and close him up. And clearly there are benefits there to get the fascia closed. So I agree. I was making that determination just based on the extent of injury. I mean, he's got pretty high, you know, he's got a small bowel injury, he's got a splenic injury, renal injury, pancreatic injury. He's got a lot of things going on there. And that's a scenario where I would at least entertain the idea of putting a temporary closure and coming back.
Yep.
Dr. Krause, was there a lot of transfusion of reds or otherwise?
Yeah, I have it on this next slide right here. So this was his total amount of crystalloid and whole blood that he got. We couldn't control the pre-hospital. He got 2 liters of crystalloid before he got to us. He did get a little more crystalloid than we typically like to give at UAB intra-op. We try to limit under 2 liters, but it was a decently long case. And then he got 1.5 liters of whole blood, and that was his all his transfusions he got.
All right, we have about 8 minutes.
All right, I'll continue on. This is his post-operative CT scans. We'll just show the quick video. This is his CT chest. And then this is his abdomen. Again, the main reasons for getting this was to evaluate the pancreatic injury and to be able to follow it. I'll kind of come back to that since that's the main area here. You can see right here is what we noted. The radiology reads, they initially read the pancreas as normal, but given our knowledge of the missile tract, we were obviously concerned in that what we saw on CT scan is a higher grade pancreatic injury. And then in our morning report the next morning, the consensus between everybody was that the imaging was definitely abnormal and probably a higher grade pancreatic injury than what we had seen in the OR. He also had a pseudoaneurysm, about 1.2 centimeters that was favored to be venous.
Is there, Dr. Krause, is there a lot to go? Because I don't want to delay things if there's many slides coming still.
There's a few more slides, yes.
Would anybody have done an evaluation of the pancreatic duct intra-op in the first operation using other means such as ultrasound, intraoperative ultrasound?
No.
Nobody does that. All right. Other comments right here, looking at post-operative CAT scan, presumably with contrast, as opposed to in the absence of a missile doing an MRCP or an MRI to look at that pancreas post-op in the stable patient. Thoughts?
Kind of an interesting choice, isn't it? It's not the greatest to look at the duct. If that's the indication to do the test is to look at the pancreatic duct, you've already had one good look at it with, you know, the eyeball. I would have thought an MRCP would have been, MRI scan would have been better, but I wouldn't have got that the same night. I can see if you've not scanned them, you want to scan and see whether, make sure you've not missed anything, bony injury or spinal injury, etc., etc. So I can see the rationale, but not necessarily for looking at the pancreas.
All right, go ahead, Dr. Krause.
All right, so post-operative day 1, the patient did well. He was extubated. He was hemodynamically was normal. He had an NG tube. He also did have a drop-off tube that was placed, feeding drop-off tube past the bowel anastomosis. His renal function was good. His drains were serosanguinous. We did check a drain amylase and a serum amylase. His drain amylase was 16,000. And so at that point, you know, we did discuss doing an MRCP, but we felt that we could see enough with the CT scan and with the drain amylase that high of 16,000. We talked that day of whether we should take him back for distal pancreatectomy or to further observe this pancreatic injury. We decided to repeat the drain amylase the following day. and then get a second CT scan to evaluate evolution of the injury instead of waiting the 48 hours. Urology had been consulted for this kidney injury as well. Post-operative day 2, again, the patient clinically was doing okay. His drain amylase came back at 19,000 from 16,000. The CT scan showed similar findings. Because of the proximal bowel anastomosis that we've kind of discussed previously, and then an amylase level that was so high, we talked with the patient and his mother that we would advise a distal pancreatectomy. And then again, the major concern was the risk of anastomosis breaking down from a pancreatic leak.
How much was the volume of the output per day?
It was about 200, 150 to 200. It was serosanguinous. It did not look like pancreatic fluid, but this was only post-op day 2.
So post-op day 2, 20,000 or so. So this is pure pancreatic juice. We're closed though. 200 cc's of effluent out of the JP per day. Is everybody going back to the OR? Stable patient, reopen that abdomen, take out the distal pancreas? Dr. Abutanos, yes?
Absolutely, especially I have an anastomosis sitting right there. The drain is only telling you what you're getting out, not what's left in there. And so in my hand, I would have been back in the OR if I didn't do it initially.
The first time. Dr. Chestovich, Dr. Brooks?
Yeah, I
Yeah,
think
I agree.
it's a difficult decision now the abdomen's closed, because you're going back in, you got a closed abdomen rather than a damage control abdomen, but it's 200 mils is not going to dry up anytime soon, and there's nothing else you can do that's effective, I don't believe. I'd go back in and sort that out.
I agree. I think you're in a window of opportunity. He's only post-op day 2. You can still get in there and do something. You wait much longer. If that pancreas leaks and causes more inflammation, it's going to make everything that much harder.
Agree.
Dr. Holcomb?
Jose, I agree with everybody here. Cassie and I were taking care of the guy in the ICU. We talked to the operating surgeon, Dr. Cox, who, like I said, would be here, but he's in the OR. We talked to the radiologist. We talked to the family. All these issues that everybody discussed, and we went back to the operating room.
All right. Dr. Krause, take us through the finish line.
All right. Radiology addended the report after we talked with them, and they noted a pancreatic injury, but we already knew that. In the operating room, we did note some mild saponification, not a lot, but there definitely was some over the distal pancreas. There was a contusion over the anterior surface of the pancreas. I think that was probably more evolution. And then inferiorly, you could see injury there. And as we dissected further, you could see that probably the missile kind of went through it, because you could see a laceration of the duct. We did a distal pancreatectomy with a vascular endo-GIA stapler, and then we wrapped the pancreatic stump with an Everest patch, and then left a drain, and we were done.
All right.
Can I ask a question about, I don't know, I don't do pancreatic surgery, so I don't know if this is still a thing, but when I was a resident, there was a little thing you could put around the stapler where it would kind of staple and seal it. Does that thing still exist, and is that done? Or was that an option? Kind of compresses the duct down to prevent a leak.
Yeah, the SimGuard, I've used it sometimes, not necessarily all the time. We just did a slow, slow compression with the stapler. We did not use a SimGuard, but then we used the Everest patch, which kind of forms a similar thing. But yeah,
we discussed that in the operating room. Cassie asked that question. I've been less than impressed with the literature on that device, and then more prone to the Everest dressing. So try to do the same thing.
Yeah, it's not, I mean, I did a lot of elective pancreatic surgery and have extensive experience in pancreatic leaks as a result of that. And it's not something that we use to staple on our stapler. We would staple that off. All we know from the literature is if you staple and suture, you increase your leak rate. I'm fascinated to know, I haven't seen evidence on Everest patch. We did some on Tacocil, its precursor, wrapping the end of pancreases, and that unfortunately didn't show a benefit, although the French group did. But I think it's a good, it's not going to do any harm, and it's a good option as a sealant.
Yeah. The Everest has more fibrinogen in it than the Tisiol did, Adam.
Yeah.
All right, finish up, Dr. Krause. Thank you.
All right, so the following day, his drain amylase went down to 1300. Serum amylase was similar, 1300. IR did embolize this pseudoaneurysm. We had looked for it, but there was big hematoma, so we just left it alone and let them embolize that. The patient overall did well postoperatively. He did have a CT scan a few days later for some leukocytosis that just showed a perinephric hematoma that was stable. He was discharged on post-op day 9. He did end up coming back a couple weeks later for a perinephric abscess. You can see the abscess here. He was treated with antibiotics, got an IR drain, discharged home, and the drain was removed a couple weeks later. He's been seen in clinic and doing well. So the reason for presentation, pancreatic injury adjacent to proximal anastomosis at the ligament of Treitz. And then the reoperation was a judgment call. Took back on day 2 for the distal pancreatectomy, given the elevated amyloids and the peripancreatic drains in close proximity to the duodenal anastomosis. I think, really the main question is what we've kind of already discussed is, doing this in the initial case, doing the distal pancreatectomy in the initial case, as opposed to 2 days later.
Outstanding case, Dr. Krause. Thank you. There's while Dr. Menengozo gets his team ready, there's a question on the line, I think that refers to Dr. Brooks' comment. Was it stated that suture plus staple of pancreas increases leak rate?
Yes, if you do both, then all we know is it increases the leak rate. If you do either, then the leak rates are, in the literature the same. But if you try to augment your staple arm with suturing or vice versa, then you increase your leak rate. So just do one.
And this is on fresh pancreas, not pancreatitic pancreas or tumor.
Fresh pancreas, no, not, yeah. The pancreas is going to leak whatever you do. You can throw whatever you want at that, it's just going to leak. So I'd be interested, did you go over, how much proximal did you go to the injury? Because this was a progressive injury over those 48 hours. Did you give, 1, 2, 3 centimeters of gap?
Yes.
Yeah, probably centimeters. 2 centimeters or so.
We talked about that, right? We went how far? I don't know, a couple centimeters, Cassie?
Yeah, that's a couple, I think.
Yeah. We made sure that we were Adam, to your point, made sure we were proximal to the area in the zone of injury.
Cool. Great case.
Yeah, I thought this was, number one, it was at the end of Cassie's fellowship year. That picture was in the operating room with a junior resident. They did the case. I watched. I ran the sucker. And, this guy had a gastric injury, a ligament of Treitz injury, and a pancreatic injury. It's a little unusual combination. And then, to stand there 2 days later and go, should we go back or should we just suck on the drains? I thought it was an interesting judgment call. I think it was the right thing to do. I'm unaware of a prospective randomized study that would tell us what to do in this case.
All right, thank you, Dr. Mendoza.
Great, thank you, Dr. Pasquale. Thank you, Dr. Krause and the panelists for the great case. We're moving forward with Dr. Gerd Daniel Pust. Dr. Pust is Professor of Surgery, Director of Surgical Intensive Care Unit, and Associate Program Director of the General Surgery Residency Program. He's affiliated with the Ryder Trauma Center, the Jackson Memorial Hospital, Miller School of Medicine, University of Miami. Dr. Pust, it's a pleasure to have you here presenting this case. I'm sure we're going to have a great discussion.
Thank you very much for this kind introduction. Good afternoon. So I'm presenting a case on multiple gunshot wounds to torso and extremities, and we want to talk about the sequence of operative approach and management of complication we had. I have nothing to disclose other than that I'm happy to announce that the chief resident and the fellow in this case have successfully graduated and are on their own job now, and were not available today, so I got the pleasure to present the case here to the group. So this is a 16-year-old male who came in at 4:15 in the morning with multiple gunshot wounds. You can see on the right-hand side the entrance and exit wounds where he got hit, but basically left shoulder, scrotum, pelvis, and ballard lower extremities. He came in profound hemorrhagic shock with a heart rate of 160 and a systolic blood pressure of 55. He was still mentating, so he was very anxious, obviously. On secondary survey, he had significant abdominal pain. Also, I could not identify an obvious gunshot to the wound to the abdomen itself, only to the scrotum, and nothing on the lower back, but he had concerning abdominal pain on examination. He had a tourniquet in place on the left thigh, very proximal, just below the inguinal ligament, which was placed by a police officer on scene which I believe saved this patient's life. Otherwise, he would have probably been exsanguinated prior to arrival. Where you see the large star on the left thigh just below the tourniquet, there was a very large exit wound, I would say about 5-inch in diameter. And you pretty much could see there was a lot of muscle destruction. You pretty much could see the femoral vessels in there. So they were basically open to air. So the tourniquet in place had complete control of the bleeding. There was no active bleeding from that wound with that tourniquet. And you see metabolically is a profound shock. So I have the first round of questions for the panelists, and maybe Carlos, you want to go over it in terms of whole blood versus blood components. Should we activate MTP? Do you see any role for X-rays at this time, or would you go straight to the operating room? And maybe you can comment on if this patient should be intubated in the trauma bay, or if we would try to intubate there.
Great, thank you, Dr. Pust. I think you have excellent questions, and I'm sure that the panelists will address that. So let's start with Dr. Brooks. What are your considerations here?
So whole blood, if I could get it. Unfortunately, we're still negotiating. A lot of centers are still negotiating for whole blood. MTP activation 100%. And I want to get X-rays of the chest and the abdomen. But for this time, I can convince my colleagues not to CT this one, 55. So we're going to be heading up to the OR for intubation in the operating room. I think if you tube the patient downstairs in the bay, you're going to have a real problem on your hands. And equally, opening a tourniquet to let the patient exsanguinate, it's not something I tend to practice.
Great, thank you. Dr. Abutanos, what are your thoughts?
Yeah, I agree. We have whole blood here, and definitely that's where you would get MTP, obviously, for sure. So the patient will be going to the OR in our hand as well. I would not look at the tourniquet to confirm if there's a vascular injury. I think that's a trap, and somebody already did a good job by controlling that. Last thing I do is just undo that. Absolutely no role for the scan in our hands here. The trick comes in this intubation trauma bay versus the OR. And this is where kind of you flip more toward the CAB versus the ABC in here, this aspect. And for us, he will be in the OR, and the intubation will happen there instead of delaying more downstairs. The only thing I'm thinking about is just the X-ray aspect. And this patient had a complaint of abdominal pain, and I actually didn't see if the number of his bullet are even or odd, which were kind of one. Yeah, so you got 5, so you're missing 1. And it most likely been into the belly, it went through the belly. Either way, you have peritonitis. And so that's the only thing that, if depending how well set up we are, there's a quick the chest X-ray and a abdominal X-ray, then go to the OR.
Great, thank you. Dr. Chestovich, any comments?
Yeah, so at my hospital, I agree. I would get whole blood if I have it, but we don't have it. So if they're at my hospital, they're getting blood components. Massive transfusion, 100%. Absolutely. This guy's got multiple holes, and there's a really good chance, he's a tourniquet, really high chance he's going to need it. I definitely think there's a role for X-rays, and I would probably X-ray quite a bit before we go to the OR, just to get a little bit more information, because I like X-rays because you can get them quickly, just takes a few minutes, and you can get a lot of data if you combine the X-rays with your physical examination. And the two that I'm really concerned about are that right shoulder gunshot wound and the one basically in his groin, in his penis. You don't know where those went, and those could be in his abdomen, they could be in his chest, they could be anywhere. And I think that's going to definitely change my operative approach, because I'd want to know if I have to go and do a laparotomy or if I can go and focus on that leg. And if he's unfortunate enough that he's got both going on, then you might even have to get a second surgeon, one person to operate in the abdomen, another person to focus on the leg, assuming that there's a vascular injury there. It sounds like there's a good chance there is. We don't know yet, but I'd want to know that. So I would definitely get a chest X-ray. I'd get an abdomen pelvis X-ray, and I would probably get a few shots of these limbs just to try to determine, is there a retained missile, and just try to get a basic understanding of the trajectory and which ones we got to worry about. So that's what I would do.
Great, very interesting. Thank you. Dr. Holcomb, any comments?
Yeah, we're blessed to have whole blood pre-hospital and in the ED. So this guy would get both of those depending on which EMS agency was bringing him in, certainly in the ED. Absolutely activate your massive transfusion protocol. I agree with the comments on the chest and the abdomen x-ray. This is also a role for fast. Depends on your ED and who's doing it. You could have fastest chest. You just need to know if there's lots of blood. You really don't, I mean, you're looking for a lot of blood, right? So you're looking for where to cut first. In his chest, in his abdomen, or in his leg, would not open the tourniquets, would not get a CAT scan, and would intubate in the operating room. I would encourage, we need to, and Jose, I think I saw your message, what is he bleeding out of his rectum? You got to worry about where these things are going. So roll the guy, take a look at his back, take a look at his anus, see if there's blood coming out. If he can talk to you, you can ask him if he's been shot before, right? And has retained missiles. Sometimes that can mess you up as well. To
Great.
the OR.
Great. Thank you very much. So, Dr. Pust, back to you.
Yeah, thank you very much for those comments. Yeah, I tend not to do a lot of x-rays. If I have a straight gunshot to the abdomen, I usually skip them and just go. But as you mentioned before, you're dealing with a gunshot to the shoulder, so it could be in the chest. You're not sure if something is in the abdomen, pelvis, so I decided to do x-rays on this patient. And you can see on the chest x-ray on the left shoulder, there's some shrapnel there. It's hard to see, but there's basically no penetration into the thorax. There's no hemopneumothorax. And you can see in the pelvis, there's some bullet fragments there. And you can see it when actually through the scrotum hit the inferior rami, fractured it, and then some shrapnel continued into the abdomen, which explains why he has this abdominal pain. So you're in the operating room now, and my first question I have, you see he got 2 units of whole blood in the trauma bay, and his blood pressure came up a little bit, and he's still tachycardic and in shock. You're in the OR now, anesthesia setting up for intubation. What are you going to do with the tourniquet? So this is the tourniquet placed from the police. You're going to leave it in place and prep it in, make it part of the field, put some Hewgleys on it. Do you take it off and hold pressure on the wound manually and prep around it? Would you exchange it to the pneumatic OR tourniquet we have, so you're able to inflate and deflate during the case? Also, I have to warn you, it was pretty proximal, so I'm not sure if you would get that above the injury. And then what would you address first? So the tourniquet has complete control of the bleeding. He's not bleeding from the leg right now at all. So would you decide on going to ELAP first, or would you defer the ELAP later? Maybe you did the fast and you didn't see a lot of blood, and deal with the vascular injury first. Comments?
Perfect. Let's go for another round then. Dr. Abutanos, want to start this one?
Sure. First, I have a quick question. You didn't give us on the physical exam. Did he have pulses in all of his extremities?
Yeah, except the left leg, because the tourniquet is up, so there's nothing there. The other extremities, he has pulses. Left upper extremity has pulses. The right leg, he has multiple gunshot wounds, but he has good palpable pulses in the right leg, with no active bleeding from the right leg. Yeah,
gotcha. We've had with this patient, and there are a couple of aspects with regard to the tourniquet. We've had exact scenarios where we did take the tourniquet off, especially if that was the main thing we're concerned about. My biggest concern is that patient additionally had, peritonitis and other part. Like I said, the tourniquet is doing its job. So in this case, I would, tempted to, prep the kind of the other leg, if possible, exchanging it to an OR tourniquet that we can have. Again, all depend on its physiological parameters. So a pneumatic OR tourniquet, if possible. If not, I would just left it. And I would explore the belly. I would not, the femoral vessels are not my concerns initially. Explore the belly, and the whole reason about switching pneumatic OR tourniquet is the extension that we may need to do from the belly to the pelvis to the upper extremity, if need be, to control any of the great vessels in that area.
Perfect. Dr. Holcomb, do you agree?
Absolutely. This is like a combat injured guy. There's thousands of them on the battlefield. Do the laparotomy, figure out if there's bleeding in there, stop the contamination. We didn't talk about the timing, but probably came in pretty quickly. By the way, I would congratulate the police officer in the ED for saving his life. That takes like 10 seconds to do, and they really appreciate that. So open the abdomen, figure out what's going on, stop the big bleeding, stop ongoing contamination. You can isolate the femoral vessels there at the inguinal ligament. If you, depending on the proximity, you can go right through the inguinal ligament if you need to. Open that whole thing up, fix the vessels, put a shunt in. You know, you can do lots of things right there, but he is not dying from his leg in the next 15 or 20 minutes while you sort out the abdomen. And by the way, after 2 liters or 2 units of whole blood, he's still in profound shock and extremely tachycardic. Better, but still lots of shock, right? Lots of hypotension.
Right, exactly. Thank you. Dr. Chestovic, any comments on that?
Yeah, I completely agree. I would leave the tourniquet on, explore the belly. You gotta, you can, in a relatively quick amount of time, unless you uncover torrential bleeding, in which case that's going to be where you need to be anyway. You can get in there, you can staple off contamination, you can pack the abdomen, and once you have that temporized, then you can look at the leg and see what's going on there.
Great. Dr. Brooks?
Yeah, I think we're all on the same page. I think it shows you how useful that X-ray was. It tells you where to go in first. So with that fragment, the missile fragment being in the abdomen, so I'm doing XLAP, controlling any bleeding we encounter there. I'm prepping in the tourniquet, especially if it's groin level, and I'm going to control his vessels intra-abdominally, and then I can get rid of the tourniquet and stop worrying about things. So as though it was a high amputation from Afghanistan days, I control his vessels within the abdomen, and then we can take the things off and explore it at our leisure. But quite agree, he's not dying from this at the moment.
And can I offer a quick question though? Like, see, for me, even though I did get the X-ray of the abdomen, it would not have changed my approach, even if that missile was not in that place. You have peritonitis, you have abdominal pain on this patient, and you could be lulled into saying there's nothing in the belly. I would have still went to the abdomen in this patient because of that presentation. If you have through and through it, you would not have seen that gunshot wound, and you got peritonitis, you got to be in the belly, and you could always control the vessels from within. So that's the only thing I would just say about the X-ray, and kind of a little bit in defense of Dr. Pust being able to, Daniel being able to go in straight to the OR. Either way.
Great, thank you very much. So Dr. Pust, it seems that everyone is in favor of doing the laparotomy first. So tell us what you do.
Sounds good. All right, so we're in the OR with the laparotomy. There was 3 small bowel injuries. There was not a little bit of bleeding from the mesentery, nothing crazy, not a lot of blood in the abdomen. We mobilized the medial rotations from both sides. Not a complete Maddox maneuver, didn't move the spleen kidneys, just the lower part to get exposure to the distal aorta and cava, and to make sure there's no injuries from those shrapnels you saw on the pelvis. And then we did exactly what Adam mentioned before, Dr. Brooks. We put a vessel loop around the left external iliac artery in the pelvis, got control of it, and then put a vascular clamp on it, and then take down the tourniquet. At the end of the case later on, we also put a suprapubic catheter after we dealt with the vascular injury, because the patient had a complete transection of the urethra, and we're not able to put a Foley. Actually, we tried to put a Foley, but it came out through the scrotal laceration, so it was a complete transection. So we did a suprapubic catheter to control that. So for the vascular injuries for the next round for the panelists, so what we found was a destructive injury of the SFA and the femoral vein, both transected. Who should handle those injuries? Number one, should we do this? Should we call vascular surgery service? And that's number one. And then what about routine embolectomies? And what about shunting versus repair in this patient? So I can tell you a little bit about the physiologic. He's still hypotensive, tachycardic. His temperature is about 35. He's a little oozy, so he's cholopathic. I did not give him heparin when I clamped the vessel because of that. So that's kind of his physiology right now. So maybe we can comment on that.
That's great. Thank you. So let's start with Dr. Chestovic.
Well, this guy has superficial femoral artery transected. I think you're looking at a bypass here. I don't think this is an interposition graft. I think in my hands, I'm calling a vascular surgeon. I haven't done a bypass in quite a while, and this is a complex injury. So I would have a vascular surgeon do it, but I know that at some institutions, the trauma surgeons do these. I think I would do a routine embolectomy just to, I think you assume that there's likely with the tourniquet, with getting all the, products to promote coagulation. I think that there's a good chance there's going to be a thrombus in there. So I think I would do a routine embolectomy. If the patient is stable, I think I would move towards immediate repair if possible, as opposed to the shunt. So I think I'd want to know more about that. Femoral vein ligation, I think I would probably err on the side of ligating it unless it looks like it would be easy to repair. And SFA, I think I would probably do vein interposition, assuming you could get vein. And routine fasciotomies, for me, the answer is yes.
Great, thank you. Dr. Abutanos, what about your thoughts?
All right, so this case, we handle that ourselves, especially in the initial aspect. So this patient, looking at entire physiology when he came in, I think what Dr. Holcomb already explained earlier, that the patient's still in shock, and now you've added a big operation on him with regard to his belly, trying to control and the injuries on the inside. So he's getting an Argyle shunt. That's all you're doing. He's just kind of, we don't do the routine embolectomy, not in this initial case. Because of physiology, we ligate the vein and we do fasciotomy and get out. This, you gotta be quick, fast in your thought process here in terms of I'm definitely shunting, I'm definitely ligating, and I'm doing a fasciotomy and I'm getting out. No
Dr.
time for vascular surgeon in our hands.
Yeah. Dr. Abutanos, would you do both of the fasciotomy, both of the thighs and the legs? Both of the thigh and the leg?
We don't do the thigh, we do the lower extremity. We have came back on a later day to have done the thigh, and that's usually after we do our measurements and see what they're at, but usually not in the initial operation.
Great, thank you. Dr. Holcomb, do you agree?
Yeah, I agree with everything that's been said. I think there is a division between older and younger. There are some good things about being older, not many, but some. An SFA is a big artery and relatively easy fixed. However, given the physiology, I anticipate this patient, he gets a shunt, ligation of the vein. And, the fasciotomy is really interesting. I certainly was trained to do lots of fasciotomies. I would look at the time element here. How long was the tourniquet on? How long? And then how much crystalloid versus balanced product, whether it's whole blood or balanced, did he get? I think we're doing fewer fasciotomies than we did in the old days because we give less crystalloid and there's less edema. But I would err on the side of fasciotomy, but not necessarily mandate it. Whereas 10 years ago, this would have been a mandatory fasciotomy. Today, I think it's a judgment call. Close observation in the ICU and fasciotomy, no hesitation to take them back and do fasciotomies if we need to. I almost hesitate to say that, right? But the last guy who had a ligation of his common femoral vein and an arterial repair did not get fasciotomies, and he did fine. But we looked at his leg every hour.
Yeah, monitoring, right?
Fasciotomy, but last comment, fasciotomies are not free and easy. They are relatively morbid. And in somebody's coagulopathic, they can bleed a lot from them.
Definitely. Dr. Brooks, any additional comments?
No, I agree a lot with what colleagues have said. In my group, we'd have got control of it and then invited vascular in and then told vascular when to stop. I think that's the issue, inviting our guest surgeons in that they want to do a full repair. And like my other colleagues, this is always going to be a shunt. I think the one thing that pushed me to do fasciotomy, it's not routine, is the femoral vein transection and the femoral vein ligation. With that ligated, if it was just the SFA, I'd be the nuanced patient specific. So not guidelines, just looking at the patient, looking at all those factors. With the femoral vein tied off, I'd be nudging the group to do fasciotomies.
Yeah, it's a good comment, Adam. I don't disagree with you.
Great, thank you. Dr. Pust, we still have some 6 minutes for the presentation, so you go ahead.
Right. For repair, the ones who would do repair right away, would you do graft or vein? That's my last question. 16-year-old, any difference? Age doesn't matter. Always vein, always graft for femoroids?
contralateral vein.
Yeah, he's got a bowel injury, right? So I would, even though it's in the abdomen, this is separate. I would lean towards vein. I would prep the other leg.
Sounds good.
Same here.
So basically that's what we did. We debrided the artery, we did an embolectomy, and then put a 14 French artery shunt in. We ligate the femoral vein and did fasciotomies. Now you have the situation that you did all that. It's you're in the OR. It's 5:50 in the morning, and you got the shunt in. We did embolectomy distally. We got good clot out from distal, and then had good back bleeding from the distal end actually before we put the shunt in. And we had good inflow proximal. We put the shunt in, cannot get a pulse, and have a hard time finding Doppler signal. What do you do next? So shunt in place, but you're not really sure what's happening in terms of perfusion distally.
Great, Dr. Abutanos.
Yeah, so you did the embolectomy already, and you did not get any result.
No, yeah, we did. We got clot out, and we had some back bleeding after the embolectomy. However, I still cannot get the distal pulse. So the question is, what is this? Is there still more clot? Is there, is it spasm?
Could be
How should we
vasospasm.
interrogate that? Or should you think it's just spasm and you're going to go out no matter what? Or
Yeah,
do you have to have a Doppler signal to leave the operating room? Let me put it this way.
Let me tell you, we've had this a lot, and I think the mistake is just sit there and wait till you get a Doppler signal, and we don't do that. So we do our shunt. If we have a Doppler signal, fine. Yes, you could interrogate it once, but then the patient is spasmed. He needs to be warmed up. He needs to be resuscitated. You got to get out, and don't worry about the leg right now. And so I think you already did the shunt, and in our hands, we will get out. Our issue with calling vascular is just delays even more time for us in the OR, and that's part of that's at least that's what we do.
Great, Dr. Brooks, the same thing, or any additional comments?
I think we have the same experience that quite often you getting a very poor Doppler signal with the shunt in. I would look at see what I thought the perfusion was like. My experience is the same as yours. It's quite often spasm. And at this point, I want to be out the OR. So I would take the move to go out of the operating room. I think more the shunts are useful in that you can screen quite quickly and do it on table through the shunt. And I think that does give you an additional opportunity if you just got it, with screening. So it's a bit nuanced between the two. If I had screening available and they were there, I'd screen and make sure I had flow to the knee, and then I'd call it at that point.
Great. Dr. Holcomb, the same thing?
Nothing to add. I agree with everything. It's physiology determines lots of decision-making here. It would be nice if you had, I don't know the name of the shunt, Tide Rasmussen shunt that has a T on it. Adam, you might know that you can do an A-gram through. But if not, get out of the OR, warm them up, fix them up.
Great. Dr. Chestovich, any additional comments?
No, I concur with the previous points. I agree. I mean, you got to get them out, you got to get them warm, and then reassess.
Great, thank you. Dr. Pust, I think you can move forward. We have 2 minutes.
Okay, so moving forward very quick. So I did do an on-table angiogram just to make sure that there was flow distal all the way to the foot, which you had. A quick picture here, you can see the shunt there, and you see the pretty destructive injury to the muscle. We just extended proximal and distal where you see the skin incision, but the center you see was as it is. And we went out with fasciotomy. The muscle is viable. There's another gunshot down there you can see, but he has flow. We went back to the operating room the next day. We removed the shunt, did again embolectomy, and did a saphenous vein interposition repair. And we did in the abdomen a small bowel resection ×3. There was also 2 little holes or 3 little holes from shrapnel, very small ones, which I did a primary repair. Close the abdomen, get out. Here you can see the vein, and then in position here. I'm moving fast because we only have a couple minutes because we had a complication. I like to put retention sutures on the fascia. I don't pull them right away. I wait a little later, and we put some chest tubes underneath so the sutures don't cut in. There's a lot of different techniques to do it, but I think it's important to keep some traction on the skin to achieve primary closure later on. the complication was that subsequently that wound, he had necrosis of the skin, underlying muscle, and it got infected. So we had to debride him several times and put vac dressings on and get that cleaned up. However, on day 20, 3 weeks later, he has a sentinel bleed through that wound. And the fellow went and see the patient, he put a pressure dressing on, and they opted to do a CT scan at that time. And you see the following, where the arrow is. That's the distal side of the anastomosis. So we obviously have a concern that there's a pseudoaneurysm. And what would you do now? What are the options here? Do you think it can be endovascular stented? We think 3 weeks out, it's probably the cause of that pseudoaneurysm is probably infectious, since we had prior wound infection issues. So in that setting, can you do a vascular stent or not? Extra anatomical bypass? And then again, who should be doing this? Should we call for help now or not? I was lucky that day. I wasn't in the other hospital. We covered 2 hospitals, so I wasn't there that day. So I had a reason to get out. But so we in our case, yeah, called vascular surgery to do it. But what do you think?
So Dr. Pust, I think for due to the time limit, I think you could move on, and we can ask specific questions in the next
Sure.
slides.
So that's basically it. So you know what happened is vascular then did an extra anatomic bypass with vein from the other leg again, and ligated the thing, and he did fine. You see, this is the thigh wound. Subsequently, we did a primary closure, mobilized skin flaps, and then one of the fasciotomies we didn't get close and ended up doing a skin graft. And he was subsequently discharged with the complication.
Wow, great case. Thank you. So let's do a final round. Dr. Abutanos, any comments?
No, just to say this great job, you know, in getting this patient through, you know, and the whole value of him being at your center, level 1 center, with all the modalities that you need and the proper thinking and management. But I'm very appreciative of all the comments and all the colleagues.
Great. Dr. Chestovic.
Yeah, those were 2 great cases. And this one especially, I mean, this guy, I mean, I don't know what his ISS was, but it was pretty high. The fact that you got him through and he kept his leg is pretty remarkable. So excellent job.
Great. Dr. Brooks, any comments?
The only comment, he's got sort of a pattern, a wounding pattern that looks like a high energy transfer rather than your basic low energy transfer handgun. And how much debridement, because you could, I don't know, I didn't see how much, when was the wound closed, how much debridement of the muscle there was at that time. But I guess that's one thing to think about, that you want to get rid of that dead muscle. Otherwise it will do what it did, cause infection, and then you get a blowout.
Right. So the issue is, you know, we kind of needed some muscle to cover the graft, right? So in the first operation, it was already an issue because, as you said, there was so much destruction. And I think because probably we left some necrotic muscle behind and then eventually got infected, leading to all of that. One thing I didn't mention is that subsequently also the urology service did a primary repair of the urethra through the scrotal injury, and we left the suprapubic catheter in, and then eventually did a urethrogram, and it healed up completely, and then the suprapubic came out. What always helps for those kids, obviously, is age, right? 16-year-old, you know, they can take a lot of hits, so that obviously helped us here. But was a good case. Thank you for the comments. The one thing I learned also from our vascular surgery, maybe like just as a last final comment, you know, they're absolutely, it's a hard no on putting an endovascular stent for this pseudoaneurysm in an infected field for obvious concerns. So extra-anatomic bypass is probably the way to go to get out of that field and not put a permanent foreign body into an infected anastomosis. It's tempting, right, to just float a little stent up there. It's the thing, if you like, about versus doing a big operation, but my understanding is it's not a good idea.
Yeah, definitely. So Dr. Holcomb, any final comments?
Yeah, I agree with Adam. This wound in the guy's thigh looked like a high energy wound rather than a low energy. So debridement of lots of muscle would be anticipated. We saw a lot of these in Iraq and Afghanistan. And our vascular colleagues started writing that they put PTFE in almost as a 2 to 3 week temporary, not a shunt, right, but a conduit, anticipating because of the high energy that there would be infection. So it allowed them to get good infection control. You're not as worried with coverage right away, and then replace it in an extra anatomic vein before the pseudoaneurysm and blowout occurs. So, you know, everything you've said is, Dr. Pust is exactly correct. There is an experience with these kind of wounds and these kind of legs, and it is just a little bit opposite of what we have all been taught in general surgery. But I would say it's on the fringe of vascular surgery. It's high energy, combat wounds, extremity wounds, just like you've talked about. But I would congratulate you guys on saving this kid's leg. Well done.
Great. I want to thank you, all the panelists for being here today. Dr. Pust, thank you very much for presenting. And I'm handing over to Dr. Pascual and Dr. Martos.
Yeah, I wanted to thank everybody. We're a little late, but it was wonderful cases, wonderful discussions, collegiality, and cross-pond discussions, which is always good. Antonio.
Yeah, I would like to say, you're completing 12 meetings now with the Pan American and WST joint conference. I would like to say that I'm very proud that it's happening. It has been a hard work for many, many people. Dr. Jose Pascual has been fundamental, has put a lot of energy, a lot of work for making this happening. There's a lot of people in the background backstage to make this happen. Brea, Gladys, Kevin, thank you for making the technical part even tighter and fixing the issue that you had. So Kevin Miller from UMIT is working really hard to make this meeting happen the way it's supposed to be. And especially I'd like to say thank you to Liliana. She has been going through a tough year and she has been managed this meeting very well. This is the last meeting before the Pan American Trauma Conference. They're going to be in 2 weeks. The last meeting before this BITE conference, they're going to be next week, starting tomorrow, actually. And we're going to have one more meeting before the WST conference. It's going to be in Las Vegas in September. But Pascual, thank you very much for supporting this, for making this happen. And just let everybody know, this meeting started 15 years ago under the guidance of Dr. Raul Vaturi. Dr. Vaturi was executive director of Pan American Trauma Society and had the vision, and you performed more than 600 meetings so far. And it's just an honor to continue the legacy, keep the legacy of Dr. Vaturi alive. And it's just an honor to have WST with us in this journey. Dr. Pascual, thank you very much for making this happen, okay? Looking forward to meeting you all in Las Vegas in September.
Thank you very much, all. Have a good day. Bye-bye.
Thank you.
Bye-bye. Thank you all.
See you in Lima.
Bye-bye. Yep.